Afternoon, everybody. Welcome to OHAO's online presentation of COVID and implications for occupational hygiene advice and actions. I'm Anne-Marie Landis-Groom, President-elect for OHAO. So following the success and feedback of our first virtual town hall last month, OHAO made the decision to organize today's session. For some of you who may not be familiar with OHAO, because we do have some non-members in attendance, our membership includes predominantly professionally accredited occupational hygienists. Occupational hygienists are specialized public health professionals who are dedicated to identifying, assessing, and controlling hazards in the workplace. And we're employed across all sectors and government. The mission of OHAO specifically is to advance the profession of occupational hygiene and serve the interests of our members, which aims to, hold on, let me just advance the slide here. Well, it's not sharing, that's okay. The mission of OHAO is to advance the profession of occupational hygiene and to serve the interests of our members, which aims to advance the profession through professional development, public and legal recognition, networking, and public education. For more information about OHAO or membership inquiries, please go to our website or email our office at office@ohao.org. So now I'd like to introduce to you our speaker for today's session, Dr. John Murphy. Dr. Murphy is president of Resource Environmental Associates, a specialty occupational health and hygiene consulting firm in Ontario. Dr. Murphy has been practicing for over 30 years in the field. He holds a Doctor of Philosophy and a Master's of Business Administration from the University of Toronto. He is also a certified industrial hygienist, registered occupational hygienist, and a member of the American College of Epidemiology. He also serves as an adjunct professor at the Dalai Lama School for Public Health at the University of Toronto. Dr. Murphy has extensive experience and expertise in infection prevention and control as it relates to COVID-19 and pre-COVID-19 pandemics. With respect to COVID-19, REA was retained in early March 2020 by Health Sciences Association of British Columbia and the National Union of Public and General Employees to advise the BC government's public health policy regarding the use of personal protective equipment by healthcare workers caring for COVID patients. REA's report is publicly accessible on the HSA website. REA has recently been retained by healthcare services, unions, legal counsel, and associations across Canada to provide expert advice regarding personal protective equipment when caring for COVID-19 patients. And they've also recently provided advice to a national retailer on infection control and prevention measures for retail stores nationwide. So with respect to pre-COVID-19 expertise, his infection prevention and control experience includes Legionnaire's disease cause finding investigations and Legionella remediation across Canada, the US, the Caribbean, and this also included that 2005 Legionnaire's disease outbreak at the Seven Oaks Home for the Aged in the city of Toronto in 2005. Other pre-COVID-19 pandemic expertise revolves around the production of another report in 2009 regarding the use of personal protective equipment by healthcare workers in relation to H1N1, the swine flu outbreak. And in 2008, he was hired by the Ontario Ministry of Government Services to evaluate workplace and public risks under future respirable disease pandemic scenarios to formulate a plan for infection control for the Ontario Public Service. And last but not least, he also did a slew of advisory work and operation related to respiratory protection in the respirator fit test clinics during the GTA's SARS outbreak. So without further ado, I want to hand it over and introduce Dr. John Murphy. So John, you can unmute yourself and share. John, can you hear me? Okay.
Just give me one sec here. Let me try something here.
I clicked on my stop sharing.
Okay, how's this?
There you go.
Good.
Thanks very much, Anne-Marie. Good afternoon, everyone. I'm going to get rid of my video for a second, actually for about 45 minutes to be more precise, and then share my screen. So just before I start, I should say, while I am on faculty at the Dalla Lana School of Public Health at the University of Toronto, what I'm covering today is shouldn't be interpreted as any sort of official position of that institution. Now, what I'm going to do by way of coverage is ultimately get to providing some thoughts and comments with respect to the types of advice that I think occupational hygienists should be providing to their client workplaces. And I should say too that the focus of the work settings that I'm going to talk about is actually work settings generally. It's not intended to be focused on healthcare settings. That is a fairly broad subject area itself in terms of infection prevention and control in healthcare. So that's not really the focus. It's workplaces generally in the context of getting up in operations again. And I think when it comes to that type of advice, we can talk about two buckets: actions that make sense and actions that don't make sense. And I think that where you put those actions in either bucket needs to be informed really by consideration of three things. One being what we have seen and what we know with respect to the population subgroups that are at risk. And it is the case that not everybody shares equal risk when it comes to this particular disease. We need to be informing our clients as well based on what is known about modes of disease transmission, and also the way in which things might evolve in the future with respect to possible incidence scenarios in the coming months and year. So the starting point is to really have a look at the evidence with respect to the at-risk groups. And I think the best way of doing that is by studying the patterns of hospitalizations, ICU admissions, and deaths. So I'm going to do that. I'm going to show you some statistics very shortly, but before I do, I'm going to introduce you to this slide and what it means. And I think it helps organize the information that is available with respect to the population subgroups at risk. So what we have here is basically a number of ovals representing different segments of the general population. And at the top, the arrow that is facing to the right is really intended to represent different degrees of risk of infection and or severity of disease if infection occurs across those different subgroups in the population. So, for example, to the left, we have youth. Then at the center, we have healthy adults in the general population. And then to the right, we have a number of other subgroups: elderly adults. Within that group, we have long-term care residents. Beneath that, we have adults with specific pre-existing conditions. And at the bottom, we have highly exposed workers. What we're going to see is that the evolution of the outbreak thus far in Canada has really discriminated in the sense that these are the groups that have suffered most of the morbidity and the mortality, and that really healthy adults in the country have faced relatively low levels of risk in terms of being identified as cases, and if they have been cases, they generally haven't progressed to be very severe cases. Youth at the left side, hardly any severity and no mortality. So we're going to have a look at this in a second. Just before I continue though, Jason Boyer, I am hearing some clicking of keyboard. Could you have a look at who's left unmuted and maybe address that? Okay, so let's look at elderly adults as a starting point. What I did in this table that you're looking at is I had a look at the published data on the Health Canada website, which provides a roll-up of severity information for the entire country based upon provincial individual summaries. And of course, in Canada, provincial ministries of health individually collect and report data for their respective provinces. So Health Canada takes that information, consolidates it, and as of May 26th, they had provided percentage distribution data with respect to the various cases that have been identified for different age groups across the country. Now, I should say that as of May 26th, they had only actually gathered sufficient information to classify cases in terms of their severity as far as hospitalization, ICU admissions, and deaths goes for about half the total reported cases in the country. So their data as of May 26 was based upon approximately 40,000 cases. However, at the same time, they did indicate that there are approximately 83,000 cases in total. So about half of them have not been adequately classified to date. So for purposes of the presentation, what I did do is I took a bit of liberty, which was to take the distribution data for the first 40,000 and extrapolated it to the balance of the cases. So this may not be completely accurate when the day is done, but my guess is it's probably not going to be too far off the mark. If we have a look at the age-specific data, you'll see that to the left, I have shown different age brackets, starting with under 19, going all the way up to persons 80 and plus. So again, this is for the overall Canadian population. And you see in the next column, the actual numbers of people in those age brackets based upon Statistics Canada's population data as of July the 1st, 2019. So that denominator as well is not quite up to date, but it's probably reasonably accurate in relation to where we are on May 26th. Digesting individual numbers like this is almost impossible, but I wanted just to give you initially a sense of, what the data source that I'm dealing with. But I'm going to move on and look at a table that I hope is a little more informative in terms of understanding what's going on as far as age risks go. So for the first two columns in this table, we have the same information. We have the age groups, but I've converted the absolute numbers into percentage values for the population generally. And then the rest of the table is really providing age stratified information with respect to cases, hospitalizations, intensive care unit admissions, and deaths. Now, the first column under the heading cases, entitled age specific cases as percentage of total cases, is just that. It's showing you, for example, that people under the age of 19 have constituted approximately 6% of all the cases identified in Canada to date. If you carry it along, you see we go through the different age brackets all the way up to 80 plus, and in the 80 plus category, those people represent 15% of the total cases identified to date. Now, that in and of itself, again, is not particularly informative unless you take the population numbers for those age brackets and then apply the case incidence over the population size for that segment. If you do that, you can calculate something that looks a little more like a rate. So in the column beside that to the right, we have the actual case rate per 10,000 people in that age group, formulated in the manner I've described. You can see that there's quite a difference. So people under 19, the case rate is 5.9 approximately per 10,000 people. When we get into the broader adult age bracket, let's say age 20 up to 79, the actual case incidence rate is pretty constant. It's low 20s, 40 to 59, a little bit higher, but it's dramatically higher once we get to the 80 plus age group, where we're looking at 79.3 cases per 10,000. So again, these are cases. So these are people who've been identified through testing that come back positive. Doesn't tell us anything, though, really about what happens to them once they've been identified. So to understand a little bit more about how they're impacted, we need to look at the other data in this table: hospitalizations, ICU admissions, and deaths. If we look at hospitalizations, again, younger age groups, the percentage of cases in that age group, that's what we're looking at under the heading as percent age specific cases. People under the age of 19, only 0.8% of those are actually getting hospitalized or requiring hospitalization. The numbers go up until we get to the 60 to 79 age bracket, and then they drop for the 80 plus. Why that's the case is not really spelled out anywhere, but I suspect it has to do with the idea that people who are in that age bracket and are identified as cases often do not get hospitalized, even though they may be very, very sick and may eventually die. They may be in other care settings like long-term care homes, retirement homes, or they may simply elect to not admit someone who has the disease and is in that age bracket. So if we have a look at that data, hospitalizations, we can similarly get some idea of a rate. So we have to the column beside that, the hospitalization rate per 10,000 cases in the age group. There's none. For under age 19, it's 0.0. It increases as people get older, and then it is again the highest in the 80 plus age group, where we're looking at 23 cases per 10,000 in that population bracket. ICU admissions, we see really the same pattern. It's highest in the plus 80 group, but really what is most dramatic is the values at the end in the last two columns. So we see that as a percentage of age-specific cases, we again start with very low numbers in the lower age groups. They go up a little bit in the 20 to 39, 40 to 59. They increase a fair bit in the 60 to 79 age bracket, and dramatically in the 69%, sorry, to 69% in the 80 plus age bracket. So what does that mean? It means that 69% of the cases in that age bracket are dying. And if we look at that translated into a rate per 10,000 people in that age group, for people who are over the age of 80, it's 55 per 10,000. That's a huge contrast to what we see in the other age brackets where they're really, really low. So really, when you start to look at the data this way, it really looks like this is an issue not of a population-wide pandemic that affects everybody. It is really a population pandemic that affects people who are very old in the population. And we're going to look at that and drill down a little bit more as we go. Now, we've heard a lot in the news about conditions in long-term care homes, and there was a media report the other day that disclosed a internal memorandum produced within the Canadian Armed Forces regarding conditions that they observed or their members observed in the Ontario care homes that they were deployed to. Very, very shocking, I think, that many people will find that conditions were as described. And we've heard media reports a lot, obviously, about deaths in long-term care homes. So let's have a look at what's going on in that setting. Now, as I mentioned before, in Canada, the provinces decide what they report and how they report it. Across the country, really, Ontario is the only jurisdiction that's providing any level of detail of data publicly with respect to the trends that are going on in long-term care and retirement homes. Now, the graph that I've put up here is based upon the Ontario statistics. So Ontario has been producing a daily epidemiological detail report going back to, I guess, the third week of March. What I didn't look at every single day. I looked at every fourth day, and I simply tabulated the data and then I graphed it. Now, what this graph is actually showing is the total deaths, which is the blue line, the deaths amongst persons age 80 plus, which is the orange line, the total number of deaths contributed by people in long-term care settings, which is the green line, and then the total number contributed by people in retirement homes, which is the purple line at the very bottom. The reason that the lines start at different points in time is because Public Health Ontario, which produces these reports, changed its reporting practices at different points in time. So as the patterns evolved, their reporting practices evolved, which makes a certain amount of sense. The thing that's interesting, I think, when you look at the trend is that from the time reporting started with the first death in late March through to the latest report, which was dated or for data up to May 26th, we see that the number of deaths, and on the left axis we have the absolute numbers, the number of deaths for persons aged 80 and over largely has paralleled the total increase in deaths along the way. The percentage figures over time, you'll see in the next table, were about 70%. So every time there was a report, there were about 70% of those people in the 80 plus age group. What's interesting as well is that when you look at the long-term care environment deaths, and these are residents, not employees, they seem to trend as well in the similar pattern. And then when we add retirement homes in, they're fairly stable. But if we look at the data in detail, which is shown on this table, there are some other patterns that I think are interesting and raise questions. So I'm gonna go through this in a little more detail. The starting point here, I think, is probably to look at the May 26th data. Now, I should say I hadn't mentioned that I have asterisks appearing at various slide positions. This is just to remind me of certain points that I want to make. So don't worry that it doesn't have a footnote or something associated with it. So May 26th, we see the latest values for total deaths in Ontario of persons aged 80 and over, and what percentage they contribute to the overall mortality. It's 69%. If you look below there, all the way down to April 28th, you see that it actually has hardly changed. So as the deaths are being reported, it's about 70% folks over 80. Now, for long-term care residents, the percentage of deaths represented by long-term care residents as of May 26 was 63%. In retirement homes, the figures are 6% as of May the 26th. The reason in this table that I only go back to May 28th is that, sorry, April 28th, is that PHO only started reporting retirement home deaths around that time. So it doesn't make sense to do trending prior to that period, even though this graph that you saw a short time ago does go a little further back in time. But anyway, if you have a look at the figures for LTC residents and retirement home residents and add them up, together they represent 69% of the total Ontario deaths, which coincidentally is the same figure as the total number of deaths for persons who are age 80 and above. Now, one of the things that we don't have from the Ontario PHO reports is any age distribution data for the cases that die in long-term care and retirement homes. So we don't really know if the people who've been dying in long-term care homes and retirement homes are all over 80. Probably they're not, probably some are younger. But if they were all over 80, what it would mean is that really essentially the, almost all the mortality is coming from that environment. But people on the call probably know of cases of individuals who were over 80 and not in those environments who died. So I'm sure that this isn't really an accurate portrayal of the relative contribution of long-term care and retirement home deaths to the deaths of people who are 80 and over. But if we look at it another way, we can go and say, well, let's imagine that some of those long-term care and residential home or retirement home deaths include people who are perhaps 70 and over, even though this probably is not entirely accurate, because I know from my own experience that you have people in long-term care residents who are of all different age brackets sometimes. So if we do the data this way, we find that 96% of the deaths in Ontario have been people over the age of 70. We find that the sum again of retirement and long-term care homes is 69% of the total deaths, which would mean, if that assumption around 70 plus being the group that have died in long-term care and retirement homes, if that's a correct assumption, then those two groups together represent 72% of the total mortality. So again, what it leads to is the conclusion that this isn't necessarily a pandemic that puts the entire population at risk. This is, looking at age as a factor and long-term care settings as a factor. It's really a pandemic that has taken its toll in those environments, and that to a large extent, younger people and healthy people haven't really suffered. Now, we haven't talked too much about the mortality and the morbidity in people who are in younger age groups. So let's say 20 to the 69 groups. In Canada, unfortunately, I haven't seen that the federal government or the provinces have put out a lot of data on pre-existing conditions as correlates to COVID-19 hospital admissions, for example, or other morbidity indicators. However, some other jurisdictions have. So I think the best data that I've seen so far relating to the question of pre-existing conditions is actually coming from the CDC in the US. And they have fairly extensive data on their website that you can download and manipulate and play with. The data that I'm showing you on this table is actually current as of May the 20th. And what it is showing is the total pattern for the presence of certain pre-existing conditions amongst COVID-19 hospitalized patients in the total US population. The CDC actually provides age-specific breakdowns of this, and it's very interesting because if you look at the age-specific data, which I didn't bother putting here, but take my word for it, the pattern of pre-existing conditions doesn't vary a whole lot across different age groups, which would suggest that certain pre-existing conditions are independent risk factors for COVID-19. And with some of these pre-existing conditions that appear to be independent risk factors, there are papers that have talked about the relationship between depletion of angiotensin converting enzyme 2 receptors on cells and the behavior of SARS-CoV-2's S-spike protein and the way in which those interact to cause immune changes that appear to result in increased risk of infected persons moving on to having more aggressive disease and had complications and more severe outcomes. So it does appear to be the case from the evidence thus far that there are independent pre-existing conditions that increase risk. Now, in this table here, I haven't listed all of them. I've listed those which in the CDC tables account for 10% or more of the identified pre-existing conditions. I've also shown what these look like in relation to the US adult population generally, because of course it doesn't make sense to look at a pre-existing condition associated with a particular disease state like COVID-19 unless you know whether that pattern is consistent with the general population. So when you have a look at it, I'm not going to go through all the figures, but I've given you a delta in the second column from the right edge, which is showing the incremental percentage of that pre-existing condition amongst COVID-19 hospitalized adults as compared to the US population generally. And these estimates for the US population generally, I should say, aren't all from CDC. They come from a number of different sources. And then in the last column, I've given what I call in brackets in quotes RR, which is really just kind of a rough relative risk calculation. I don't want to pretend it's a real one because it's not, but it just gives an idea of the extent to which these conditions appear to be associated with increased likelihood of you being a COVID-19 hospitalized adult in the US. The reason I've asterisked neurologic disease is because when you read the footnotes in the CDC data, it actually indicates that a lot of that is dementia. So that's probably not an independent covariate, though there are papers that indicate some brain physiological and biochemical changes that occur might increase the risk of someone getting COVID-19, but it's probably correlated with age as well. So I think the key takeaway from this one is, again, that in addition to age advanced age being a risk factor, that for people who are not of advanced age, these conditions are also risk factors. And the data to date hasn't been sufficient to indicate the extent to which these explain cases in the groups under 80, but it appears to be the case that ultimately these types of things will probably explain those cases. There are, of course, always exceptions to the rule, but at this point, the data isn't really available, or it hasn't been worked up to an extent that it provides a clear picture of these things. So that's the story to date as far as pre-existing conditions go. The last category where we see elevated risk is amongst what I'm calling highly exposed workers. And I'm using that term specifically because what I've seen in the literature thus far and in the government statistics indicates that it's not simply healthcare workers that are at risk, at least not in every jurisdiction. So I'll elaborate on that in a bit. I'm going to start with Ontario. Ontario, again, in Canada is the only province that's really provided a lot of detail with respect to the numbers of healthcare worker cases amongst the total set of identified cases in the provincial population. So in Ontario, as of May 26th, the PHO report has a tally of 26,483 identified cases. Of that, 4,536 are healthcare workers. Now, the way that they have segregated the healthcare worker cases is they are distinguishing between healthcare workers in an institution where an outbreak has occurred and healthcare workers who are not in an institution where an outbreak has occurred. So they're making that distinction. The idea, I think, being that, or the inference possibly being that the healthcare workers in the outbreak institutions got it from, it was from patients or that type of scenario as opposed to a different scenario. So if we look at those figures, the total healthcare worker caseload is about 17% of all the cases in Ontario to date. The breakdown for those is that 1,721 or 6.5% of all the cases have been healthcare workers in environments where outbreaks have occurred, 359 in hospitals, and 333 in retirement homes. Now, the notion of outbreak is an interesting one. So I went and had a look. I searched around and tried to find how PHO has defined it. Found one of their documents, and basically what it said, and I don't know if this is still the operational definition, but for the document that I found, which wasn't very old, it indicated that any case in an institution involving a patient/resident or a worker caused the facility to be deemed to have an outbreak. So I'm assuming that was the basis for this classification, but I don't know for sure. Now, once you have the data on the number of healthcare workers who have been identified as cases, it's possible to calculate the percentage of that workforce in the province that has been identified as the case. So the Canadian Institute for Health Information has statistics with respect to the total numbers of healthcare workers in the province. And for that purpose, they really are mostly including regulated health professions, but they're also considering a number of other common occupations that are care focused in health settings. So their 2018 data had a tally of 511,517 healthcare workers in Ontario. Out of an Ontario population of 14,711,827, which is the Stats Canada estimate for the first quarter of 2020. And using that data, what we would come to is the conclusion that 0.89% of Ontario's healthcare workers have been cases. So that's 4,536 people who are healthcare workers and cases out of approximately 500,000 healthcare workers in the province in total. That compares to the population case rate generally, which is 0.15%. And that figure is calculated simply by taking the total number of cases in Ontario, subtracting out the healthcare worker cases because they don't count, and taking from the denominator the number of healthcare workers out of the population. So we end up with 0.15%, and that would suggest that if you're a healthcare worker, you're at about a 6-fold increased risk of getting COVID-19. Now, that doesn't say anything about severity, and the data on hospitalizations and advancing to ICU is really not very extensive. The mortality data is also not very extensive. We do know that there are 4 or 5, I think, reported cases now of healthcare workers in Ontario who have died, all from long-term care settings. But statistically, across other jurisdictions that I've looked at least in the United States and UK, which are probably most comparable, the rate of healthcare worker death is extremely low. So it's not, there are not a lot of these who are dying, which would also suggest that they are in the lower age risk groups and possibly in the lower comorbidity groups, but we don't really know. Anyway, it's a fortunate thing that we haven't had more of those. The other thing is, just as I guess an aside comment, in terms of how Ontario's total healthcare worker caseload compares to other jurisdictions, I had a look at Sweden, Germany, Italy, UK, US. Can't remember any other jurisdictions offhand, but a short time ago I had a look and did a comparison, and I think the range was 10% to 24% of the cases were healthcare workers. Now, this slide that I'm showing here is kind of interesting. This is from the UK government website. They have a really, I think, very good website with a ton of information about what's going on in the UK. Unlike the US and Canada, the UK website actually has a lot of occupational information, which is really, really good. So they provide you with numbers of cases by occupation, they calculate risk rates, that sort of thing. This particular image that's here is one of the items that's on their website. It's actually interactive, not on my screen, it's not, but what it's showing is really these individual circle clusters. Each one represents a particular occupational category. And this particular slide that I'm showing you highlights some of the healthcare workers and the appraisal of the folks who put this together with respect to the comparative risks that these people face as a function of the frequency with which they are encountering people with infectious disease, and that's indicated by the vertical axis, and the frequency with which they get close to those people, and that's indicated by the horizontal axis. When you go on to this website, you can actually hover over these circles and it'll tell you which occupations they are. It'll tell you the number of people they estimate are in those occupations in the UK and so on. There is a version for the US as well, and I think that this whole little app that produces this actually came from some US source, but it's very interesting. The reason I put it up is in part because I think it's kind of an interesting tool conceptually to look at, because you can go and say, oh, you know, I'm in this industry, what types of occupations are in my industry? You can go to this and kind of get, you know, some notion of the relative risk they may face. The other reason, though, is that in the UK, one of the things they have discovered is that one of the highest risk groups for COVID-19 is actually taxi drivers and bus drivers, which is interesting. When I looked at it about 3 weeks ago, I guess, the numbers of cases there for those occupations and the rates actually were fairly similar to healthcare workers. So it makes you think a little bit about possible mode of transmission, which is what we're going to get to next. So let's talk about transmission modality. There's obviously been all kinds of debate and argumentation about different modes of transmission in relation to COVID-19. It's not a new argument. It's gone on for a long time. It happened with SARS. It happened with H1N1. It's a perennial thing. And there's actually a ton of literature, particularly on the issue of the significance of airborne transmission. Now, I'm not going to get into a big, long review of the literature. I haven't got time. It's kind of the subject for maybe you know, a day's worth of these types of presentations. But I'll tell you that my conclusion, based upon looking at now about 350 papers on this topic over the past 25 years, is that the main mode of transmission for COVID-19 is close proximity inhalation of non-visible virus-laden respiratory droplets. And I've tried to be precise in my terminology. And I think we need new terminology to talk about this, because I really do think that a certain amount of the debate is an unnecessary debate over the question of droplet versus aerosol. It's really a false distinction. Many people will know this. Back in the SARS era, and even in H1N1, it was common, I found, for public health documents, whether they were agencies in Canada or internationally, to define a droplet as a visible droplet, and to define an aerosol as a non-visible droplet. Oddly, that definition has actually changed, and now I find it's pretty common that public health authorities define a droplet as something that's 5 microns and larger. Well, industrial hygienists know that something that's 5 microns is actually respirable, and it's what industrial hygienists would call an aerosol. And this has kind of interesting implications for people's beliefs about modes of transmission, but also implications, obviously, for their beliefs about what constitutes adequate respiratory protection. So that, again, is kind of a longer discussion, but I think it's important to try to eliminate that false distinction between the terminology of droplet and aerosol, because we're really talking about a continuum of airborne liquid globules that float through the air, that are emitted by the airway, and that are available for people to inhale. So I like to talk about inhalation as a mode of transmission rather than droplets or aerosol, because I think it eliminates some of the confusion around this whole concept. Now, as far as the evidence base goes for this, as I said, I'm not going to talk about that really in much detail today, though I am going to point out a few things. If you are interested, over the past couple of months, for the work that I've done, particularly relating to COVID-19, I have assembled a bibliography, which I'm calling a partial evidence base, because I'm sure there's a lot more out there that I haven't found, that deals particularly with aerosol transmission of respiratory viruses, including SARS-CoV-2. And there's been a surprisingly large number of papers specifically on SARS-CoV-2 in the past 6 weeks, as there has been generally on this particular virus and then COVID-19. So that bibliography is something that has been widely distributed by Andrew Kutz, who's the curator for the Global Occupational Hygiene List. And if you want it, feel free to contact Andrew or me, and I'll be happy to provide it. But just in terms of summarizing the lines of evidence, they go back a while. So again, I've said this isn't new information. This is a subject that has been talked about for a long time. There's opinion, there's lab studies, there's clinical studies, there's many different types of evidence that go back 25 years or more in relation to seasonal influenza, SARS-1, H1N1, MERS, and now COVID-19. There's also been a lot of information developed in the last decade, particularly in terms of our understanding of the production of aerosols by the human airway. So that's probably a good place to start, because we know now from many different studies that everybody, whether healthy or ill, emits fine liquid droplets from their airways. The size fractions, the spectra of those droplets differ quite a bit. When you breathe, it's in the range of 0.1 to 1 micron generally. When talking, about 0.1 to 20 microns. And there are studies that show that the volume, the number of droplets that are emitted by talking is substantially increased as opposed to just breathing, up to 50 times more. Coughing, you emit non-visible droplets in the range of 0.1 to 50 microns. And really, you only start to see a significant amount of visible droplets through sneezes. But even then, the spectrum is very wide, 0.1 to 1,000 microns, 1,000 microns being a millimeter, and visibility for most people only starting at around 50 microns and then above. So that's one important piece of evidence. We are constantly exhaling tiny liquid droplets. The tiny liquid droplets that we exhale when breathing or that are emitted by talking and coughing easily travel 2 meters. Intuitively, you can think about this by recognizing how far cigarette smoke goes. If you see someone exhaling cigarette smoke, the aerosols emitted there are a combination of solid and liquid, and that's kind of how far they travel. In cold weather, you can kind of illustrate the same thing just by exhaled breath. But when someone sneezes, those droplets can go much, much further. There was a paper that was published a month or so ago by a research group at MIT in Boston that showed high-speed, super resolution imagery of what it looks like when someone sneezes. And they talked in that paper and a subsequent paper about the implications for transmission of SARS-CoV-2 or COVID-19 and implications for respiratory protection. But the thing that's interesting is that that's not the first paper they published on that subject. I mean, they didn't talk about SARS-CoV-2 or COVID-19, but they published a few papers that have shown this behavior of the airway and how far the overall spectrum of droplets go when someone has a forceful sneeze. So certainly what we emit from our airways goes quite a ways, and other people can be a target for that. Now, point 3, SARS-CoV-2 virus has been determined to be present in patient respiratory fluids from pretty much the onset of symptoms to day 7. SARS-CoV-2 RNA has been detected in patient room air in patterns consistent with emission by exhalation in clinical settings in studies published to date. There also was an experimental lab study that was published by Van der Meulen, I think is the pronunciation of the name, et al., back in early March in the New England Journal of Medicine, that reported on the persistence of infectious virus on a variety of different surfaces and in air, and came up with estimates of half-life and compared SARS-CoV-2 to SARS-1. And that was a study that looked at infectious material as opposed to just RNA. SARS-CoV-2 envelope morphology has been found to be stable in air for 16 hours through studies of electron microscopy examination of viruses before and after suspension. Certainly it's possible for someone in proximity to someone who is breathing or talking or coughing or sneezing to inhale the air that person emits. That's pretty obvious stuff. There's quite a bit of evidence now that a high percentage of people who are positive for SARS-CoV-2 have been asymptomatic or very mildly symptomatic. There have been serology studies done now in a few different jurisdictions involving both random and non-random samples that are suggesting that perhaps 15 to 25% of the populations in those areas have been infected, even though the percentage of positive cases identified through swabs have been much, much lower. We know as well that airborne droplet and virion concentrations diminish with increased distance from the source. In sort of an idealized model with a 30% expulsion cone from someone's mouth or nose, you'd have approximately 1% concentration at a distance of 6 feet or 2 meters more or less, as compared to the concentration at the source, which is probably fair to say is the theoretical basis for a 6-foot social distance. I mentioned already that the SARS-CoV-2 spike protein latches onto the ACE receptor, and the alveoli particularly are rich in that receptor, as are the terminal bronchioles, and those are the primary loci of infection for this virus. The clinical and community transmission pattern evidence to date is consistent with close contact exposure. And ferrets are used and have been used for a long time as the animal test system for respiratory disease transmission for humans. And studies that have been done have actually found that when you infect ferret A and put ferret B in a cage nearby, far enough away so there's no droplet in the classical sense contact or contact transmission, that you will infect ferret B. And it's obviously not a study involving one ferret. So this airborne inhalation mode of transmission has been demonstrated experimentally in what is considered to be a valid test system for humans. So that's kind of a summary of the evidence around inhalation transmission. Very quick summary. But a lot of the advice that we've seen come out from public health authorities has been about contact transmission. And we've seen media reports, of armies of people in spacesuits applying sterilants or sanitizing compounds to streets and subways. We had our federal medical officer of health imploring people not to touch their face and this type of thing. So, where does that come from and what is the evidence? I think that traditionally in infection control and prevention as a field and in clinical medicine in a healthcare setting, there's pretty well established body of information with respect to how you minimize transmission of nosocomial infection and protect patients in those settings. And certainly contact precautions and actions you take to prevent contact transmission is kind of a well-established part of that body of information. And there's certainly quite a lot of evidence in that setting to indicate that for certain types of transmissible microbial diseases, contact transmission is significant, and actions to clean surfaces and keep hands clean and so on are important for preventing transmission. But is it the same in the case of SARS-CoV-2 and COVID-19 disease? There was concern about this, I think the concern about contact transmission was reinforced by a paper that came out that I've already mentioned in the New England Journal of Medicine back in early March that showed survival of COVID-2 virus on different materials and in air, and that's what you see here. And I think that kind of, gave cause for concern over the possible significance of contact transmission. But it has been known for some time in relation to other viruses that are deep lung infection viruses that surface transmission is not a particularly efficient way of getting sick. So the dynamics of surface transfer are not efficient. This slide is really kind of illustrating the notion. This has been demonstrated to a certain extent experimentally in controlled lab studies, but it's also, and by computational models that really essentially show that, if someone coughs on their hands, let's say, which is person A up in the top left, if they were to expel 1 million viruses onto their hands, only a certain fraction survive. Hands are actually fairly good at killing viruses, and SARS-CoV-2 has been found to kind of fit in that category with a half-life on hands of about 30 minutes. If someone has that on their hands and they touch an object like a doorknob, again, only a certain percentage gets transferred. And these numbers that I'm showing here on the slide, they're purely arbitrary, so don't go and say these are in any way, authoritative, or that I said this is actually the rate of transfer. It's not, just to illustrate the concept. But, again, you get a certain percentage on your hands from coughing, a certain percentage of that survives, a certain percentage can be transmitted to an object, a certain percentage survives on the object. Someone else comes along, now we're in the bottom row with person B, they touch that object, only a certain portion of it makes it onto their hands, only a certain portion survives on their hands. And, the geometries of all these objects are different as well, so you get different surface areas with contact, and you get different degrees of loading. And then, you touch a mucous membrane, whether it's your eye or your nose, you put your finger in your mouth, only a certain amount of transfer happens. And then finally, that has to make its way into the target tissue, which in this case, again, are the terminal bronchioles and the alveoli. But even if you get viral transfer from, let's say, your tear duct to your lungs, which apparently is physiologically possible, you have to have enough dose delivered to actually initiate an infection. And we have, innate immunity and we have acquired immunity. So, it's the models and the controlled experiments where this kind of thing is done just don't indicate that it's a significant mode of transfer. As well, you get different epidemiological patterns of disease outbreak when you have significant contact transmission, and that's just not showing up in this case. So even though there has been a lot of messaging around this, it seems to be the case that the messaging has recently changed. So you probably have seen, maybe you saw media reports earlier this week that the CDC has updated its information on its website. And this is from their website as of that day. And the highlighted yellow piece is probably the key piece. So it says it may be possible that a person can get COVID-19 by touching a surface or object that has a virus on it and then touching their own mouth, nose, or possibly eyes, though this is not thought to be the main way the virus spreads. But we are still learning more about how it spreads. So I think the final qualifier is an important one, but to date, it doesn't look like this is a big thing. Let's talk about projection of patterns until it peters out. So petering out meaning going away. Nobody really knows what it will be. There is a document that is published by the Center for Infectious Disease Research and Policy at the University of Minnesota that talks a little bit about what might happen. I should say this, and the images that I'm showing you here are from that. They talk about 3 different scenarios. The first one being peaks and valleys, meaning that, you know, we might continue to see this idea of there being lulls and then kind of a rise again in identified cases and mortality, and then a lull and so on. And that necessarily won't happen in the same location or amongst the same groups. In theory, it may happen in different regions, different parts of the world, and so on. The next scenario they say is fall peak. So this is kind of the second wave fear that you've seen in the media talk about, that, oh, there's going to be another outbreak in the fall, and it'll be worse than this one. That is based largely on the experience of the Spanish flu. And the label I've got on here is actually wrong, because below it says scenario 3, slow burn Spanish flu. In fact, scenario 2 is Spanish flu from 1918, 1919. But the Spanish flu was quite a different situation than we have now. I mean, it was in the context of a world war, population, health issues, very, very different. Healthcare systems, very, very different, obviously. So just because it happened in 1918, 1919 doesn't mean it's going to happen now. And then the bottom scenario is essentially that this is it. Like, we've seen the worst, and it kind of diminishes, and then it becomes part of the sort of the load of seasonal respiratory disease, which is what has pretty much happened with H1N1 and other viruses in the past. But no one really knows. So I think we just have to kind of monitor how things evolve, and that will you know, determine how important workplace advice is. So what does it mean for workplaces? Well, I think, you know, if you reflect on the evidence around transmission modes and at-risk groups, that you come to some conclusions with respect to things that make sense and some that don't. So in terms of things that make sense, and I'm just about done for people who are kind of wondering about the time, I think communicating facts about at-risk persons is really key. Like, the data shows that this is not a general population risk. This is a high vulnerability population subgroup risk. And that means that not everybody needs to be really that concerned about themselves getting sick, or if they get sick, the evidence doesn't show that they're at huge risk of getting very, very sick or dying. However, if they are elderly in the workplace, or they have elderly family members or friends, those people are at greater risk. So I think it's important in workplaces to make sure that people have a clear understanding of that reality, so they can take important actions to reduce the risk of those people who are vulnerable. I think it also is important in reducing fear generally. Another action is really to reiterate ways of protecting people who are vulnerable. So the standard advice around social distancing, you know, cough etiquette, sneeze etiquette, that sort of thing, that's obviously important. One aspect that's been talked about a little bit is the idea that for facilities like hotels, which have been perhaps idled as a result of lockdowns, there is increased risk of disease transmission associated with stagnant water systems. So potential for Legionella, bacterial proliferation and liberation once these facilities are occupied again. So the usual precautions around sterilization, flushing of water systems would seem to be important. I guess it's possible as well that with stagnant water, you might have an increase in, you know, low concentrations of toxic metals like lead or copper. So taking action to reduce people's exposure to microbial agents and trace chemicals in the water system, I think is good due diligence. Proper protection and training for highly exposed workers. So we've seen that this is an issue for healthcare. In the UK, it was an issue for taxi drivers, bus drivers who are, you know, in constant contact with a large number of people in a relatively closed space with shared ventilation. So those people need to understand how to protect themselves and make sure that they use proper practices in PPE. And just because people are in healthcare is no reason to assume they know this stuff, because I think the evidence we're seeing indicates that that's not necessarily the case. Optimizing ventilation, both natural and mechanical, is important too, if in fact it is a situation whereby people get exposed from airborne viral material that they inhale. So what doesn't make sense? Well, air or surface testing doesn't seem to make a lot of sense. The concentrations on these surfaces in air are going to be negligible in the absence of active emitters. You got concerns over false positives, false negative testing, and even if you get some kind of detection, it's not really predictive in any way of risk. So that doesn't seem to make a lot of sense to me, at least. I think aggressive surface and object sanitizing in non-healthcare settings also doesn't make a lot of sense. Again, we have a lot of conceptual and mechanistic evidence that this is not a significant way that people get sick from this disease. The epi evidence doesn't really support that as a significant mode of transmission. It may, however, be beneficial from a risk perception perspective, and I understand that. But I think as hygienists, if we're going to give that advice, we need to be honest and say, look, the evidence suggests it's not necessary, and the evidence suggests it's not beneficial. But if you think your workforce is going to feel more comfortable about it, then it's not going to hurt anything. But don't sort of tell people it has benefit that there isn't really evidence to suggest to support that it does. I don't think temporary workplace closures make a lot of sense for the same reasons, but again, it may be the case that management thinks that it will allay fears. It could backfire, however, right? In that you have people decide the workplace is dangerous and they don't want to come back to it because it's been closed because it was so dangerous. Ventilation system sanitizing, I've seen advice on that too, but it doesn't make sense for the reasons that I've indicated there. I've left the best to last, which is masking. So what about masking in the workplace and in the public? Well, since the audience here is pretty much all hygienists, I'm assuming that the rationale behind doing this is understood, both from the perspective of attenuating emissions from people who are sick or asymptomatic and infected, and from the perspective of protecting people who might be inhaling their emissions. And that's really what's illustrated with the figure on the right, which is actually from a paper that just came out yesterday. But what about it? I mean, this whole idea of masking in the workplace and in public with any old mask is really very new for us in North America, at least. And there's not evidence to suggest that it actually works. Maybe it works for what I would call sneeze-borne infection. So with sneezes, as I mentioned before, the spectrum of discharge particles is much, much broader, much wider than it is with coughing, breathing, or talking. And there's a large fraction in the visible part of the spectrum, which you see in the graph to the bottom right, clustered around 100 micrometers and a little below 1,000 micrometers. So maybe it's beneficial from that perspective. You don't need specialized filter media to block large droplets. So maybe it helps for that. But COVID-19, it shouldn't say COVID-19 transmission, but COVID-19 does not produce a lot of sneezes. The clinical evidence would suggest it produces coughs if it produces either. So it doesn't appear that it's a sneeze-borne disease, if you want to use that term. And if it's the case that it really is transmitted by respiratory emissions of tiny non-visible droplets, then you do require specialized filter media. The photograph on the left is actually from that, I guess it's Berubia lab at MIT, showing what the liquids look like when someone sneezes. Another thing that's interesting about it is that we've got government officials and the media giving advice on how to make a mask and wear a mask from pretty much anything, right? Like take a t-shirt, take some underwear, tailor it and make yourself a protective mask. Well, we know that the fabrics that are used are critical to the performance of masks. We know that masks like N95s have electrostatic properties that also play an important role in their efficiency. Not the same though for underwear and t-shirts. So it's difficult to predict the protective value of masks that are made from untested fabrics worn by inexperienced users who also probably have very little understanding of the mode of transmission and the role that the mask plays in that. And the images I picked here, I think, illustrate that. So on the far left, we've got the governor of New York out wearing a bandana, which is flying up above his chin. That's actually his daughter to the right, wearing another type of mask with her nose completely exposed. And then we've got 3 images from the Globe and Mail with, I guess, a journalist showing different styles of masks, and of course he's wearing a beard. So it just seems to me it's very, very bizarre. And again, it gets back to kind of the importance of communication, education, and messaging around these things. The other thing around these masks is we don't really know what's an infectious dose. So if it turns out to be the case that susceptible people are easily infected, and they're easily infected by asymptomatic people who exhale non-visible droplets, and if these homemade masks do nothing to stop emissions of non-visible droplets, then what good do they do? I don't know the answer to that question. Is wearing masks outdoors necessary? Is another question that I think warrants some discussion. And overall, is this a prudent or strategy, or is it counterproductive? I think time will tell. So I'm out of time. I apologize. I think I've gone over by about 5 or 10 minutes from what I was allotted. And if there are questions or time for questions, I'm happy to put the camera back on and take some.
Just give me 1 second here. I'm going to bring Jason back on.
Well, thanks, John, for that that presentation. Very interesting. We're just waiting now for Jason Hoffman. He's been collating the questions sent directly to him through the chat. So we will just wait for him to get back on.
And I've taken off the spotlight video, so we're seeing you if you're there. It doesn't look like there's too many people with the video on. If you wanted to put it on, you're welcome to, but you don't need to.
Well, John, while we wait for Jason to hook up, there was one question posed to the whole group about the sharing of slides, and we had indicated that we will ask you at the end of the presentation.
I can't share the slides, but you're going to publish the video, I assume, so they'll have that information that way.
Okay, perfect. Thank you.
They can take their own screenshots.
Can you hear me now, folks?
Yep, you're on.
Hi, Jason.
Sorry if there's an echo. Maybe I could make it. Okay, maybe this is better. So there's a couple questions. One of them was, what's the difference between deaths between long-term care and total retirement homes?
Yeah, so Ontario actually considers retirement homes to be facilities where people basically go to retire and are presumed to be mostly healthy, right? Though a lot of those facilities actually will have like a dementia floor. So, for example, my mother, she had dementia. She went to a facility that was a retirement home. Pretty much, I would say maybe 80% of the people there were independent. They weren't medically frail. That's different than long-term care, where people are actually admitted because they have, specifically, they have a cognitive disability, or they have, a physical disorder, or, some other disease that requires intensive ongoing medical management. So that distinction is one that's been made by the, in reporting of the data. So that's kind of the difference. The retirement home population, in theory, would be generally healthier than the long-term care home population.
Okay, thanks, John. There was another one that was, could there be a misclassification of deaths as due to recent changes in the Coroner's Act, which requires deaths in long-term care to be classified as coroner's cases?
I don't know the answer to that question.
Okay, fair enough. You did answer another question, was should we be paying less attention to cleaning and disinfection as a result of recent information? And I think we did get to that, but by the end of your talk. There was another question around how are cases defined, and is there a consistent way to define cases?
To my understanding, it's based upon a positive swab test. So that is the basis for a case definition. I think in the earlier stages they had a broader case definition that also included symptoms, but I do believe it now requires laboratory confirmation of infection.
Okay. And then the last one that just came in here, it is for healthcare worker exposures. Is there a reason to believe the differences in reported case rates is not largely due to the increased testing rates for healthcare workers versus the general population?
That's a good question. So I think generally there's a relationship between the number of identified cases, and I use that phrase a number of times, and the amount of testing that's done. So, you know, some of the serological studies that have been done would suggest that the prevalence in the population of infection has been much higher than the rates would be suggested through the number of identified cases by, like, you know, respiratory swabs. So for sure the case rates or the case numbers that are reported, the case incidence that's reported over time is going to be a function of how much testing is done. And one of the things that I think is kind of a deficiency in the way that agencies have been reporting this stuff is they haven't been trying to correlate the case incidence figures with the testing activity, because if you actually had more information about the relationship between those two things, I think you'd have a better sense of what's really going on in the population.
Okay. There was a kudos for pointing out the inhalation terminology usage and trying to steer hygienists away from the droplets and aerosols. So that was just a comment to feedback. And there was a question of what's the reference for the half-life of virus on hands being 30 minutes? Do you remember that one, John?
I don't recall that one, no.
And they're still coming in. Can you comment on the cleaning and disinfection of commonly touched surfaces as advised by PHAC?
Yeah, I think for healthcare settings, again, it's just in line with common good practice. I think outside of healthcare settings, it doesn't. There's not a lot of evidence that it makes sense from the perspective of it being a mechanism of disease transmission, or that it reduces disease transmission for the same reason.
I think that's it for the questions that have come in. Just some thanks. Thanks for coming in, and I think it was a great talk, John. Much appreciated.
Okay, happy to.